Hello, everyone, and welcome to the webinar titled Culturally Competent Care for Eating Disorders in Diverse Populations, sponsored by the Academy of Eating Disorders. I am your moderator for today. My name is Marisol Perez, and I'm an associate professor at Arizona State University. So just to check my volume, can someone please text me in the chat and let me know if you can hear me okay? Great, thank you so much. So before we get started, just a couple of housekeeping items. All participants during this webinar are muted with the exception of the speakers and myself. The webinar is scheduled for an hour and is being recorded. It will be posted on the Academy of Eating Disorders online community shortly after we conclude. In just a few minutes, I will be introducing our speakers today, after which we will be checking their volume. During the webinar, I welcome all participants to use the chat function and post any questions that you have throughout the webinar on that chat function. At the end of the webinar today, we will have a question and answer period where I will collate all the questions that have come in and say them out loud to the speakers and give them a chance to answer each question. So to get started, I am thrilled to introduce to you today an excellent line of speakers. First, we have Dr. Maylene Reyes-Rodriguez, an associate clinical professor in psychiatry department at the Center of Excellence for Eating Disorders at the University of North Carolina, Chapel Hill. She is an AED member and is a licensed clinical psychologist in both English and Spanish, and her primary expertise is in providing culturally sensitive interventions for Latino populations, but also has experience working with patients from diverse cultural, race, ethnicity, and sexual orientation backgrounds. In addition, we have with us today Dr. Rachel Good, an assistant professor at the School of Social Work at the University of North Carolina at Chapel Hill. Dr. Good received her PhD, her MPH, and her MSW from the University of Pittsburgh. Her research focuses on the development, implementation, and evaluation of interventions to prevent and treat disordered eating among women of color. So, without further ado, Dr. Reyes and Dr. Good, I turn it over to you now. Dr. Reyes and Dr. Good, will you please try to speak?
Can you hear me now?
Oh, I can hear you now. Can you try that again?
Yes. Can you hear me now clear?
I can. Yes, I can.
Okay, and can you hear me now?
Yes, I can hear you as well. Great.
So first, I wanted to thank the Academy for Eating Disorder to have the initiative to organize this webinar about culturally competent care for eating disorders in diverse populations. And also I wanted to thank Rachel for joining me in this process. So I hope that the discussion that we will have today can help all to have more skills in order to work with patients from diverse populations. So the demographic population in the United States has changed dramatically during the last years. According to the U.S. Census projection, it is expected that the U.S. population will become minority nation for the first time in 2043. So the possibility to encounter with a client or patient with a different ethnic race background has increased. So this is why the topic of this webinar is so relevant. So the aim of this webinar are Having a little bit of trouble trying to change the slides.
So this, click on, there you
Okay, perfect, thanks. So first, the first thing is to discuss relevant cultural values when working with diverse population. Second, examine cultural adaptation that has been suggested for diverse population. And finally, examine challenges that you might encounter when working with diverse populations. So we know that historically, eating disorder has been conceptualized as an issue of white female from middle upper class. However, contrary to this misconception, it is well documented that eating disorder affect people from diverse ethnic and racial backgrounds. If we look at the research on ethnicity-based disparities in psychiatric diagnosis and access to care, reflects three main issues that can lead to the lack of appropriate treatment and can impede access to care. The first one is the poor fit of psychiatric diagnostic categories with ethnically diverse explanatory models and presentation of illness that could potentially lead to improper diagnosis. Also, in the second place, we are seeing the differential help-seeking patterns for illness across racial ethnic groups, which require different approaches to enhance engagement into treatment. And finally, the clinician error or bias due to the misperception that eating disorder are not prevalent in members of diverse population. In general, we know that the stigma of having a mental disorder is an issue within members of diverse population. What we found with Latinas is that the stigma of having an eating disorder is greater than the general mental health stigma because they feel that they are struggling with an eating disorder that belongs to white. So this stigma could trigger shame and keeping in secret the eating disorder. This is why it is important to address the clinician bias. If as clinician you think that eating disorder do not occur in members from diverse population, you will not assess the eating disorder, reinforcing the stigma and missing the opportunity to make the appropriate referral for specialized treatment and contributing to the health disparity.
So when we examine the role of clinician bias and how that seems to play a role with the diagnosis of eating disorder in white, Hispanic, and Black women, we see some issues when we think about clinicians. So 44%, according to this study, it was conducted in 2006, 44% of clinicians were able to identify the white woman's eating behavior as problematic. However, we see contrast. Only 41% were able to identify Hispanic woman's eating behavior as problematic. And then it was even lower in African American women at 17%. So in addition to what Maylin was saying, we also see some significant biases. So when we examine the prevalence in diverse populations, one thing that we're able to know, and we're able to look at the evidence. So in 2011, this is a well-known study by Marquez et al., which examined the prevalence, the correlates of impairment, and service utilization for eating disorders across U.S. ethnic groups. And so you can see here the statistics between the prevalence of eating disorders. If we're looking specifically in Latinx populations and African American, we look at anorexia nervosa, bulimia nervosa, and binge eating disorder. However, when we look at, next slide, please. When we look at the service utilization, we see some disparities. So when we examine across any, so mental health service utilization for respondents in this study with a lifetime history of any eating disorder, so anorexia nervosa, bulimia nervosa, and binge eating disorder, was higher for non-Latino whites than for Latinas and then African Americans. And so when we look specifically though in certain eating disorders, notably we see an exception with anorexia nervosa. Though it was not significant, we did see that Latinos and African Americans with a lifetime history of anorexia nervosa had a greater utilization of mental health services than non-Latino whites. So if we look across the board, we do see there are some disparities in not maybe the prevalence, but how these individuals are being able to access and receive services. So what we know, and I think what is common in the majority population, is we've learned that the over-evaluation of shape and weight are significant contributors to the development of disordered eating behaviors. However, among specifically African American and Latina populations, we might see a little bit different. There might be some alternative contributing factors that we need to consider. If we look at the cycle on the right-hand side, where we examine the role of stress, acculturative stress. What is it like being a person of color in this majority nation, and how those experiences contribute to the stress and the experiences that might perpetuate disordered eating behaviors. We also have to look at the role of racism, look at the role of microaggressions, and how these subtle experiences, or not so subtle experiences, can really begin to contribute to factors that can cause the development of ways that individuals cope with managing these stressors. We also examine trauma and sexual abuse and depression. And so we think these are factors, according to the literature, that might precede the development of an eating disorder. So it may not only be the over-evaluation of, shape and weight, but we also might need to consider some of these other things.
So we have been talking about the stigma and also clinician bias. So seems like the first step of providing competent care is by providing psychoeducation. So raising the awareness of prevalence in diverse population, not only awareness within the patients, but also within providers. Also the assessment of eating disorder with all patients. So we need to encourage clinicians, providers to assess eating disorder as a regular protocol, and also identifying the resources at the community. For example, something that I found when I started working with the Latina here in the United States was the lack of information about eating disorder. And not only the lack of information, but also information that could be more culturally sensitive for Latinas. So in that sense, we decided to develop fotonovelas as a way to start educating Latinas in terms of eating disorder. So fotonovelas is an illustrated story or novela, soap opera that is very popular in the Latino culture. And people tend to identify with characters that could help to reduce the stigma. It has been used for educating Latinos on depression and other conditions with good results. So our participants in the development of fotonovelas mentioned that they are more prompt to read the story because it's eye-catching. And also they feel more related to the fotonovelas rather than traditional brochure. So this is another way to be more culturally sensitive when we are providing psychoeducation. So here, what you are seeing is the cover of 4 scripts that we developed for females, adolescent, and adult, and for males, adolescent, and male. And something that you will see in terms of differences, when we are talking with adolescents, we tend to use more Spanish because we have the adolescent more acculturated, so they feel more comfortable speaking English. But then you have parents that they feel comfortable, or maybe they are monolingual, so they only speak Spanish. When we work with adults, then the fotonovela is primarily in Spanish.
So when we consider the role of assessment, you imagine you're in your office and you have the opportunity to conduct an assessment with someone from an alternative racial and ethnic background. Maybe they're from this country, maybe they're not. But we consider that there are a few things that we might need to address based on literature and based on our clinical experience that we think are directly relevant when we're going to conduct our assessments. So one is of course, we will examine the history of eating patterns, but then when we consider the cultural implications of those eating patterns and the cultural history of the eating patterns and how ethnic groups have developed reasons for eating, factors that have influenced their eating. And so as clinicians, our role is to really begin to investigate that and to begin to see what, when, where, how, what are the things that have affected and maybe altered some of these eating patterns so that we are able to begin to understand where maybe some disorder might have come in. Also, we need to examine how individuals are experiencing acculturative stress, how they are navigating the experience as a racial and ethnic minority here in the United States, and bringing that into our clinical work so that we are allowing our patients, allowing our clients the opportunity to explore, the opportunity to have the space to consider how the experience of race and microaggressions and just that stress might have influenced their eating behaviors. And so I know sometimes it might be awkward, especially if you're a member of the majority, to make space for that and to talk about that with your clients openly, but it would really provide an opportunity for some. And for others, it may not be an issue they want to talk about, but in the assessment to provide room for that to be an option as something that might have affected their eating behaviors. We also have recent literature that has demonstrated the role of food insecurity and poverty. So even among individuals who have experienced it previously, who are not experiencing it now, or those who are currently experiencing food insecurity, we can see the link between those experiences and development of disordered eating behavior. So it's important for us as clinicians to begin to ask questions about those experiences and to examine whether or not those might affect whether or not an individual and how they are relating to their experience of food. I can think in several of my research studies, some of my participants were managed poverty when they were younger. And so when they grew up in adults and had the opportunity to, have jobs, purchase food, they determined that they were never going to manage hunger in the same way. And so it kind of made it challenging for them to begin to develop a healthy relationship with food. Also, we have to examine trauma.
And I wanted to add some information about food insecurity with the Latino population because we have the experience of Latino crossing the border, and sometimes that process could take 1 month, 2 months. And in that sense, they are struggling with access to food during that process. So food insecurity when we are working with Latino is also very relevant to assess.
As you're talking, Millie, it reminds me of in our country, the food stamp cycle. We call it SNAP, but we distribute those benefits monthly. And so when individuals run out of those benefits, what we see is that they are more prone to, when the benefits are they have them again, to eat in a different way because they have been deprived for so long. We know that experience of deprivation really is a trigger for disordered eating behaviors. So that might help you all begin to see the link between the experiences of food insecurity and how that might be a risk factor for disordered eating behaviors. Also, the experience of trauma and sexual abuse. Again, we know more of this. We have more of a literature in the majority population, but we can also see there's more increasing evidence, particularly clinically, how we can see how these experiences may precede the development of disordered eating behaviors among populations of color. And we are well aware of also the role of certain conditions.
And also, when we think about trauma, think that maybe when we have immigrants, the process of coming from a different country to the US, that could be a trauma. Not necessary, but also that process could be traumatic for some patients.
And finally, just looking at our own self-examination. I think this is the part of our own work. And I think as clinicians and researchers, we understand the importance of this, but sometimes don't always know how to really do this work. But it's important, again, living in a racialized society that has a significant history and present manifestation of racism and discrimination, we have to acknowledge that those cultural biases have become, they're in our water. And so we can't help but drink this water. And so we have to honestly do our own self-examination as we're working with our clients from different racial and ethnic backgrounds, and begin to notice and have our supervision so that we are really able to be equipped to provide good, excellent care.
So part of the comprehensive assessment should include acculturation process when you have patients particularly coming from a different country. And in a multidimensional integrative acculturation assessment, there are 4 areas that we can assess, including the language use and preference, ethnic identity and classification, cultural heritage and behaviors, and ethnic interaction. And you will collect that information not only for the patient, but also for parents and grandparents. In that sense, can give you a better sense about the acculturation process for the entire family. Other aspect that, as I mentioned, the acculturation process, particularly when we have patients coming from a different country. And acculturation is the dynamic process of changes that every migrant faces when moving from his or her native country to contact with a new culture. On the other hand, we have the acculturative stress, which is defined as the stress experienced by individuals during the cultural adaptation process. Acculturation and acculturative stress has been identified as potential moderators of the association between body dissatisfaction and eating disorder symptoms in the Latino population, and as a risk factor for mood disturbance and anxiety. So particularly, body dissatisfaction and acculturative stress appear to interact as cross-sectional predictors of bulimic behavior. So here, I wanted to present different measures that you can use for the assessment of acculturation. For example, we have the acculturation rating scales for Mexican American, primarily developed for Mexican American, but you can make adaptation to use for other Latino subgroups. And also, we have the bicultural involvement questionnaire short version. So these 2 questionnaires are more for assess the acculturation. And then we have for the acculturative stress, we have the acculturative stress scale from Alegría, and social, attitudinal, familial, and environmental acculturation stress skills that also could be useful. Sometimes it is important to acknowledge that this is a very complex concept, and sometimes we need to have more than one measure if we wanted to capture the complexity of the concept that we are trying to assess. So here we wanted to present the evidence-based treatment that we have, in this case for Latinos. Something that we found in terms of the literature is the limited information and evidence-based treatment that have been adapted for diverse population. In this case with Latino, we have primarily 2 different treatments, the CBT sub-guide that was adapted for Caucasian and collaborator. And they found that using particularly the overcoming binge eating self-help piece from Ferber is feasible and acceptable for Latinas, but also they found that it's important of addressing the family issues. In terms of the CBT for bulimia or binge eating disorder, this is the treatment that we have been adapted for Latina here. And we also found that it's feasible and help to reduce the symptom, but also we found that one of the adaptation is to have the family as part of the treatment process. When I started adapting the CBT in Puerto Rico, I was working with adults, and I spent more than 6 sessions working with family member. So no matter the age of the patient, sometimes we have to include the family member into treatment.
So when we examine evidence-based treatment in African Americans, we have one treatment that has been examined specifically as a treatment for binge eating among African American women. So appetite awareness training, which was developed by Linda Craighead, is a CBT-based treatment that helps individuals relearn their biological signals of hunger and satiety. So this was an 8-session group-based treatment for African-American women. And so individuals were able to examine their relationship to food, were able to examine the things that, how they cope with their negative emotions. And so we were able to see both that this intervention was feasible, and we also saw acceptability. We also were able to demonstrate that individuals' binge eating behaviors were reduced. So we know that the next step is to begin to examine the efficacy of this intervention. But I think what we begin to see is that we have a foundation for the treatment of binge eating within this population.
So what are the challenges that we are facing in terms of treatment and retention? Particularly with the Latino population, there are many practical barriers. For example, transportation, childcare. However, what we found with the Latina that even if we address the practical barriers, that is not enough to engage and retain them into treatment. So sometimes the family engagement could be a way to help the Latina to engage into treatment. Having someone, a family member, a friend who can encourage them to go to treatment. And also the community-based approach seems like it's a very culturally sensitive approach for Latina, considering the migratory status, the trust issue in the system, and by having the community insert in terms of the treatment, they feel more comfortable and safe.
When we look at African Americans, you might see some similar issues with childcare and issues with being able to access treatment. But we have to recognize, because eating disorders, what we've thought of, this is only an issue in white women, the lack of awareness of eating disorders might be a problem in this population. So we have clinicians who may not see it in African Americans, and we also have African Americans themselves who may not recognize the symptoms and be aware that this may be different from normal or typical eating patterns. And so one of our challenges is to begin to create and recognize the places where treatment will be accessed, right? And how we can begin to allow this population to experience, to begin to experience the treatment. Also, we need to consider that African Americans, they're not a monolithic group, right? And so I think we have some generational differences. And so when we think about individuals who might be on college campuses, who are younger, millennials, we may see more of an increased recognition of eating disorders, but they may not feel comfortable with providers. There may not be enough providers who are equipped to provide care to treat these individuals in a way that they feel safe and comfortable. So when we think about, I think we have some opportunities and we have some challenges. So one, as you all have heard, as you all know, there's just limited evidence on the treatment of eating disorders in Latinx and African American populations. And so this, though, I think provides an opportunity as we continue to train more scholars. We have more scholars who are from various racial and ethnic backgrounds to come and begin to ask the research questions that they have the lens to really begin to see as being part of these racial and ethnic groups. And so we also need to consider that there are probably established treatments for eating disorders that may work well in these populations, but we have to consider that because we know there are challenges, existing challenges in service utilization, we might have to think about changes in setting. Where are we having these treatment? Is this better in group format? Is this better individually? Are we better including families? How are we recruiting individuals to participate in our programs and our studies? We can't use the same techniques that we've used for the majority population. And it's okay to know that things need to be different. And so again, we need to consider what might need to change. And so that might mean, as researchers, we may need to use our qualitative research methods, our focus groups or interviews, semi-structured interviews to figure out the best ways to recruit individuals to participate in our treatment, in our research programs. And then finally, we know that there are significant cultural factors that are influencing these eating behaviors. The experience of being a racial and ethnic minority in this country plays a role. And so to really begin to incorporate that experience in our treatment will enhance the experiences of our clients.
Particularly in the case of Latina, when we see the research studies, particularly in treatment, they are including primarily the most acculturated Latinas. So that means that in order to be included in that treatment, they have to be bilingual. So we need to also think about the patients, Latina patients who are monolingual, and also they need treatment. So with exception of some of the real studies, most of the study that we have found for eating disorder primarily include Latina very acculturated. So what are the values, cultural values that are relevant when we are working with Latino population? There are two specific values that are very important in the Latino culture, which is the feminism, which is the strong sense of identification with and loyalty to nuclear and extended family. So that means that family is important no matter the age of the patient. Personalism is another cultural values where Latins promote close relationships, especially with those who demonstrate respect, caring, and well-meaning. So that means that they like when the therapist call them or to reschedule the appointment or just to double check if they are doing okay. So that having this kind of personal treatment, they feel very comfortable, they feel that you care about them, and then that process could impact in terms of their retention into treatment. Other cultural aspect that you have to take in consideration when you are working with Latino is the acculturation, that we already talked about that, but also the migratory status. We know that we have here in the US undocumented Latino population, and they're scared. They're scared about approaching hospital because they associate the hospital with the system. So we need to also think about how the migratory status could affect the access to services. Language barrier, not having the treatment in their language also could be something that can impact the access to care.
So when we examine some values that might be relevant in African Americans, recognizing that all of our patients, this won't be relevant to all of our patients or all of our clients or all the participants in our research studies, but these are some factors that have been highlighted in the literature to be relevant to individuals who are African American descent. So the first is examining there's an alternative view of weight and shape. And so there may be less emphasis. You might see this in your clients on achieving the thin ideal, especially the same thin ideal that is seen in the majority population. And so again, there are differences, I think generationally, there are some differences in this, but there is a significant literature that shows that these alternative views of shape and weight might mean that the disordered eating, it might look a little different, right? It might, there might be different factors that might be propelling it rather than achieving this certain goal. Also, we have to examine a relationship to food and how, specifically among African American women, when you think about cultural pressures, there's something called the strong woman schema, superwoman schema, where women feel pressure to be strong, pressure not able to show emotion for fear of maybe being deemed an angry woman or, not being, knowing that they have to carry the weight of the world on their shoulders. And so one thing that sometimes women do is to eat to take care of themselves, right? This is a way to cope with negative affect, a way that won't be judged by any family members or any friends. It's really quite acceptable within the culture. And so it's been a way, food has been something generationally that has been used to cope with all types of negative experiences that African Americans have had within this country. And so it has such positive meaning, love, joy, so many positive things. And so when we also look at the relationship to food within the family and the community, it becomes a little more entwined and deeper. And so some of our participants and clients and patients are managing, not only their experience with food, but some of the expectations that are placed upon them by their family members on how they need to eat, and they might be questioned or may not be supported because it just means something different. And without that emphasis on achieving the thin ideal, there just might be just some conflict, and individuals are managing the stressors of this love of food in the family and then trying to navigate their own individual relationship with it.
That reminds me, Rachel, that Latino talk about food, how they feel connected with their culture. And by eating something particularly that is typical food from their country, they keep that connection, not only with their family, but also with their culture. So we have been talking about different aspects that are very relevant when we are working with diverse population. In this case, we are trying to present a model that could be more culturally sensitive for Latino population. In the case of the patient, for example, we need to work on the psychoeducation. We need to work on the stigma of having an eating disorder, understand the consequences and the severity of the condition. Some of the issue with the Latina is that they wait until the symptoms are very severe to seek for help. So we need to address how we can identify and how we can help them to seek for professional help early than that. How and where to seek help. Sometimes they don't know where to seek for professional help. I remember a case that I treated here, and she told me, there's no information about eating disorder for Latina here. I didn't know where to go. Emotional factors, the readiness to change, trust in the healthcare system and providers. If we look at the family piece, we also need to provide psychoeducation. What is an eating disorder? Sometimes the family, they think that it's not an issue, it's not a problem, because they don't know that this is a mental health condition that requires professional treatment. They don't know how to support a family member. Sometimes they make comments because they think that that is appropriate, or because they are trying to help. Instead of helping, maybe could trigger more the eating disorder. So they don't know how to help and to support the family member. Also providing support for the emotional piece, providing practical support, and how and where to seek professional help. In terms of the provider level, we need to continue working on the awareness. They need to accept and recognize that eating disorder occur in diverse population, particularly we are talking here in Latina. So in that sense, they can establish like a protocol that they can include the eating disorder as part of their assessment. Background on assessment and treatment of eating disorder in Latina. One of my experience when I came here to North Carolina, I started working, doing volunteer work in a mental health clinic for Latino population. And when I asked about their experience with eating disorder in Latino population, they say, we haven't seen eating disorder here. So for me, it was shocking. However, after working on presenting what is an eating disorder, how to assess the eating disorder, eventually they started seeing more eating disorder in their patients. So I think that is helping providers to know more about the eating disorder, not to feel afraid of, evaluate, assess the eating disorder. And also knowing that they could have the support from specialized treatment can help providers to feel more comfortable to start assessing eating disorder, in this case with Latino population. And bilingual services. We need more provider bilingual because we have Latina with different level of acculturation, and some of them need the treatment in Spanish. Most of the hospitals, they have interpreter services. That could be an option if we don't have any other resources. But we know that using an interpreter services could add other kind of complexity to the treatment process and therapeutic alliance. In terms of the system, we need to work on the practical support, transportation, childcare, provide flexible business hours for treatment, because sometimes they work hard. They work sometimes double shift, and they need appointment out of the business hours. Providing a sliding scale for patients with no health insurance. That is one of the issues that we have, is particularly with undocumented, that they don't have health insurance and they have to pay out of pocket. So we need to provide an option in terms of sliding scale. And preventing program for eating disorder in primary care setting. Usually Latino, they prefer to go to the primary care setting. So maybe that could be a good start to work with the Latino population.
So when we examine, some things we might consider as we look at the levels of intervention for African Americans, think about on the individual level, one of our first stops might be to educate on the presence of eating disorders and the associated symptoms. And then be aware that maybe these individuals might need to develop some alternative coping skills instead of using food for the experience of negative and discordant emotions. And then making sure to provide support in our treatment centers for experiences of stress, racism, microaggressions, and trauma that may be the experience of many African Americans in this country. And so then if we look at the family system, understanding that these individuals come from a rich line of food that has depth and historical meaning. And so helping these individuals begin to manage family expectations, to help provide education to their family members who might be well-meaning, but who just may not know about just how eating disorders might play out and the harmful effects of them. And so to really begin to support individuals as they manage sometimes family expectations that can be a real hindrance to making progress in treatment. And so we also need to help our providers begin to develop the awareness that it may not only be the overevaluation of shape or weight as a factor that might precede the development of eating disorders, but acknowledge some of the other things that we've mentioned, and also to highlight the role of racial stereotyping and how certain individuals don't look like they have eating disorders. So in our culture, we have been known to dismiss them and not conduct a proper assessment. And so we need to continue to help our providers begin to have training on culturally relevant definitions and norms of disordered eating behavior, and to begin to have tools to manage some of the racial stereotyping that might just be present, again, as we are part and living in the water in our racialized society. Some things we just can't help but get away from. And finally, when we think about our systems, similar to what Mei Lin was saying earlier, primary care really may offer an opportunity to treat eating disorders. We know that African Americans, they will go to primary care systems. They are apt to develop relationships with their primary care providers. And so if we team up and partner, we might be able to consider how this setting may be a place that can offer some preventive treatment, ongoing treatment for eating disorders. Also, in the literature, we see that African Americans are likely to engage in programs for weight management, stabilization, likely because of some of the numerous comorbid health conditions that especially older African Americans may be managing. And so if we include and really work to include assessments for eating disorders in our programs, in these already established programs for weight stabilization, weight management, we might also have an opportunity to prevent or treat any disordered eating behaviors that may arise.
So now we wanted to summarize all of the information that we have been sharing with you during the last almost 45 minutes. So I think that the first one is eating disorder affect people from diverse racial ethnic backgrounds. So we have to assess and provide psychoeducational This is an assessment process. Assessing history of eating disorder patterns, cultural implication of food, and cultural values are important components of assessment.
We also have discussed how we have such limited evidence-based treatments, but we do have some that have demonstrated some preliminary feasibility and acceptability, and might be good options to start with some of your clients who are of a Latinx and African American population. However, we recognize our future research really does need to examine the prevalence and the nature of eating disorders in various different racial and ethnic groups, and then develop and examine differences in treatment response.
So here you have some references that you can look at eventually if you wanted to know more about all of the information that we shared with you all today. And I think that we are ready for questions.
Okay, great. Well, thank you, Dr. Maylene Reyes-Rodriguez and Dr. Good for that excellent webinar. We're now going to start the question and answer portion of the webinar. And we already have 3 questions that have come in. And so I'm going to cover those in the order that they have arrived. And actually, I just see that a question popped up of, can I have the references? Yes, the recording for this webinar will be available probably by tomorrow, and thus the references and will be there and the slide as well. Okay, so the first question that came in was actually at the very beginning of the webinar, and the question was on the service utilization numbers that was covered from the Marcus et al. 2011 article. If you could go back and just briefly explain those numbers from that article.
Sure. So when we see, I'm sorry, okay. So in this chart, we are showing the prevalence of lifetime service utilization. So I think within the Marquez et al. Article, we were looking at mental health service utilization for respondents with a lifetime history of either anorexia nervosa, bulimia nervosa, binge eating disorder, or any eating disorder. And so when we look at, I think it's easier if we look at the last column because we see the lifetime history. So individuals had a lifetime history of any eating disorder without binge eating, I believe, any binge eating behavior. We see, so 75% of non-Hispanic whites were more likely to access services. And then we see a contrast, 62% and then 61% among African Americans and Latinx population. And then when we look at lifetime service utilization for those who had binge eating disorder, we also see some disparities. So 78% of non-Hispanic whites had higher, had service utilization, where we see the contrast, 54% in Latinx population and then 71% among African Americans. Now we see some interesting things to note in the individual when we look at anorexia nervosa. So here we see that there were a higher percentage of African Americans and those of Latinx population who had access services, who had diagnoses of anorexia nervosa. But that was not, those values were not significantly different within the article.
Okay, great. Thank you so much, Dr. Good. So we have a number of questions that keep coming in. So thank you to the attendees. So if you move further along in your slideshow to the slide on the treatment opportunities and challenges slide, this is where you discussed the challenges with service utilization that included the setting, the recruitment strategies, etc. Right there, yes. Okay, so the first question on this slide was, can some of the recommendations that you have made apply beyond the treatment of eating disorders to other disorders?
In case of the Latina, I think so. I think that in general, when we work with the Latino and talk about mental health disorder, we need to think about how we can culturally adapt that treatment for that population. I have been working, for example, with Latina with depression, major depression disorder, and CBT, for example, we found that work pretty well. So it's not necessary that we have to adapt the treatment in terms of the content, but mostly is in the delivery process. It's how we can change the delivery process. For example, when we adapt the CBT for depression, we decided to use primary care setting to conduct the treatment. So in that sense, we train the physician to help us to identify the depression disorder. We involve the nurse system and also provide the treatment, the CBT, in the primary care facility. So in that sense, they feel more comfortable going there and to receive the treatment. So I think that the recommendation that we are making for in terms of cultural adaptation can apply for any other kind of treatment, not necessary for eating disorder.
Mm-hmm. And I think we also need to consider in this country, most of our treatments were developed with the majority culture in mind. Most of our settings, most of the way we choose to approach health concern were developed, with majority culture in mind. And so if we think critically, we recognize that different cultural groups have different needs, different things they're comfortable with, different things that they're going to need in order to engage in treatment. And so I really see this as an opportunity for additional qualitative research to begin to hear more from these populations about how we can better serve them, because, there have been some challenges.
Okay, thank you. And so the next question related to this slide was that, these practical barriers are barriers for anyone, anywhere, for any disease. Are there specific factors that make these barriers more prevalent for the Latino and African American communities?
I think, so you can make that argument, but I think based on, as we talk about what we know about access to treatment for eating disorders, we see some stark disparities. And so I think some of the things that we've mentioned that have been some of the barriers to why these factors might be, is because the conception of eating disorders as something that only affects white women. And so that has trickled down from, the providers, and now it's in communities. And so we have these lies that are going on in our communities, and people don't really understand that the influence and the challenges of disorder eating, and so the support is not there. And so we also have to consider that the disparities in treatment, the experience of racism, the experience of poverty, the experience of, just microaggressions, things that are unique, I think, to being a racial and ethnic minority in this country, pepper everything. And so, yes, I think there are challenges that may apply to other individual groups, but if we think specifically about eating disorders, and we think specifically on what we might need to do to improve access to treatment for eating disorders, these are some things that we came up with.
Also, we have to think about the lack of resources in the case for the Latino population. For example, if we talk about practical barriers like transportation, childcare, maybe they can't apply for other kind of resources at the community because they don't have the document to do that. So I think that maybe this population, they have an additional barrier. We recognize that these are not unique for our population, but I think that maybe there are other factors that increase the challenges.
Okay, excellent. Thank you. So another question that has come in is if you could please provide any suggestions for questions to assess the cultural implications of food, acculturative stress, and food insecurities that in your clinical experience you have found helpful or beneficial.
Sure. Maylin, do you want to go to that slide? Okay, here we go. So I think, so when you think about the cultural implications of food, one question that I have found helpful is, can you talk, so I often ask my clients and my participants, can you talk about, some of the cultural values of food in your home? How was food used? How was food used for celebrations? What was the role of food in your community, in your home? When you think about acculturative stress, and Maylin, I know you can offer some unique additions here, but I know I'm often thinking about, especially individuals who are experiencing the stress of managing being an African-American in predominantly white environments. And so often I will just offer, can you tell me about your racial and ethnic background? Just as introduction. It's a very safe question, and so how individuals respond to that will let me know how I need to proceed. And so as individuals answer that question, they begin to talk about some of the environments that they've lived in. And, and I ask them, what has that been like? What have your experiences been like? Or if we're on a college campus, what are your experiences being, a member of a Black ethnic group here, in a predominantly white environment? What are those experiences like? And just being direct with it. I know it can be uncomfortable for some of us, but just give the space. And if it's not something that's of relevance to the client, they'll let you know, and we move on to the next question. And also about food insecurity, I often find it's helpful, have you ever had experiences where you felt like you didn't have enough food to meet your needs? Have you ever had experiences where you were concerned about where your next meal was coming from? And just, again, opening the door so our clients can begin to tell their stories and we can begin to put the pieces together and offer relevant treatment.
I think that in additional to that, we can assume that all of the presentation of the patient is because of the eating disorder. Sometimes we need to explore more than that and ask them about how was the eating pattern in their country, any changes when they are coming here to the US in terms of the eating pattern. Sometimes it's the changes on the schedule. For example, people from Spain, usually they have a different kind of a schedule in terms of their eating pattern. Sometimes we are forcing them to have a regular eating pattern as we conceptualize our regular eating pattern, and sometimes it is hard for them because it's a huge change. So we need to just pay attention about what is coming from their culture and what is the part of the eating disorder in order to help the patient to provide a treatment that could be very sensitive to their culture too. In terms of the acculturative stress, I wanted to add that, for example, we have sometimes different generation with different level of acculturation, and that could also add acculturative stress. For example, we have adolescents maybe more acculturated, and then we have parents less acculturated, and they wanted to keep the cultural values and traditions. And having that kind of conflict between parents and patients sometimes can increase the stress.
Okay, excellent. Thank you. So we have just a minute left. There was another, it was more of a point than a question, but someone pointed out that in the utilization figures, it's important to keep in mind that they're probably underestimates because we know that there are people who are getting seen who are not being detected or diagnosed with an eating disorder in the first place. And then I apologize to all the attendees. We have like 8 more questions that have come in, but we've run out of time. However, once the recording with the PowerPoint slide is posted, you'll see that that at the website, at the AED website, that the contact information for Dr. Good and Dr. Reyes Rodriguez is there. And so we encourage you to contact them and ask them your great questions and continue the dialogue. So this is a wrap for everyone. We want to thank again Dr. Good and Dr. Reyes Rodriguez for this fantastic presentation. And just want to remind everyone that we have a lot more upcoming AED webinars that will be posted on our aedweb.org website and under the events tab. So thank you everyone for participating, and I hope everyone enjoys the rest of your day. Bye everyone.